evening, everyone, and good evening, Dr. Sajjan, and good evening, all the panelists, Dr. Olimova, Dr. Elaine, Dr. Sachini, Dr. Rumman, Dr. Nikhil, and Dr. Chandrashekhar. And we welcome you all to this evening where we are going to have an exciting discussion, scientific feast in managing metastatic colorectal cancer. It's going to be a great learning experience from some of the great leaders across the world. Who are going to share their experiences in their routine clinical practice in managing metastatic colorectal cancer. And we really appreciate Dr. Sajjan to show this interest in moderating the session. And thank you so much, sir, for taking the lead in moderating the session. And without much ado, I would like to pass on this podium to you. Dr. Sachin is the Director of Medical Oncology from MAX and MAX BLK Hospital in Delhi. And he comes with an extensive experience of more than 2 decades practicing medical oncology. And he has been trained from University of Texas, MD Anderson, and subsequently he has been practicing at RGCI and BLK, and now it is BLK-MAX. We welcome you once again. The podium is yours, sir. Thank you.
Thank you, Dr. Vidya, for this kind introduction. And it's again my privilege to be amongst my peers and discuss very important issue today afternoon. And one thing which has been really challenging with a lot of oncologists across the world is to make the latest advances accessible to their patients and to care for their patients according to the latest guidelines. And doing this thing, we should actually discuss and try to find out and also collaborate with the podiums like 4-Base Cure, who have been making the molecular diagnostics accessible across the globe and engaging clinicians to take wiser decisions for their patients. So first of all, thank you 4-Base Cure for getting us together. And also thank you all my esteemed panelists today afternoon here from New Delhi and welcoming you to this evening symposium. I hope the situation at your country with COVID and Omicron and all that is relatively now easing off, because despite cancer being such a dreaded, or I would say kind of a pandemic of pandemic proportion, not that much news is not being created for cancer like we had for COVID. Even last year, we had almost more than 1 million that's happening even in India. So the kind of data which is with cancer is really stark, and we need to do something for mass media communication of cancer and how to make cancer care affordable for our patients through such meetings and also delegations with the government to make the things accessible for vast number of patients, which still is a huge unmet need. Before we started this presentation, when we were discussing informally amongst each other, we have realized that all parts of the world, molecular oncology takes a huge, it needs a huge makeover, and we need to get this molecular oncology into our clinical practice as soon as possible. So, Dr. Vidya, thank you again. And can we have the presentation from your side loaded? Shubham, will the presentation be loaded from your side? That is very kind from you.
Sure, sir. So just give me a minute.
Yeah, sure. So before the presentation is loaded, I'll start my presentation. The presentation is just a way to discuss the things. So the topic which we are going to discuss today, that how do we do the molecular landscaping of colon cancer and how that molecular landscape has changed over the last 10 years. So colon cancer now ceases to be one disease. So colon cancer, if one patient of colon cancer comes today, I not only need to think about which side it is, what is the age of the patient, what is the demography, geography, and what is the microbiome, what are the genes which are responsible. So all those things have become important treatment decisions. Whether the it is right-sided, left-sided, has got a huge impact upon the way I treat a colon cancer patient today. And compared to this, a decade back, things were different, but yes, today all the oncologists have to be aware of these emerging biomarkers in colon cancer. So welcome again, and then we now formally start the presentation. So I will welcome my panelists. So we have Dr. Chandrashekhar Hospet. He is concerned medical oncologist at Nilai Cancer Institute, Malaysia. We have Dr. Elaine Cargullo. I'm really sorry for my pronunciation because they might be different geographically again. She's a medical oncologist at St. Luke Medical Center, Philippines. Welcome, ma'am. Dr. Kamruzzaman Rumman. He is clinical and molecular oncologist, associate professor at National Institute of Cancer Research and Hospital, Bangladesh. Welcome to you, sir. Dr. Nikhil Pande. He is concerned medical oncologist at SCG Nagpur. Dr. Sachini, Rasnayake, consultant oncologist and senior lecturer, University Hospital, Kotawala Defense University, Sri Lanka, and Dr. Zilola Olimova. She is consultant medical oncologist, Vita Alliance Hospital, Tashkent, Uzbekistan. So welcome to all of you, my esteemed panelists, and now we move to the, can we have the next slide put up? We go to the case now, and then we start discussing. Next slide, next slide. So we have been seeing that the molecular landscape of colon cancer has been evolving, and we can just see from 2004 to 2020, there have been a lot of evolution which is happening across various mutations and also the sidedness. So the colon cancer evolved from KRAS to PAN-RAS to involve PD-L1, then MSI and HER2, and then rare markers like NTRK. So a lot of tumor biology markers have come up into the molecular profile of colon cancer. And now we treat such cancers with the more availability of genomic information, especially in the metastasis setting. Next slide. So, and we also seen with the introduction of biologicals and personalization, our survivals have been increasing. So in 1990s, the survival of a colon cancer patient who was metastatic, the median survival was only 9 to 10 months. And with newer therapies, we're able to see the median survival has increased to the tune of 39 months. So almost 4-time doubling of the survival in the metastatic setting, which was not possible without advances in molecular oncology. Next slide. So coming to the case. So the case is, it's a male 67-year-old, no prior pregnancy. The patient has got diabetes type 2, hypertension also is controlled with the antihypertensive drug. The patient also got BPH, which is controlled on selective alpha blocker. So the patient presented in 2013 with acute bleeding, abdominal pain, diarrhea, constipation. The patient tumor located was in sigmoid colon. It was a left-sided tumor, stage 2 colon cancer managed with colectomy. So the patient did very well with colectomy. At that time, patient was observed, and in 2017 there was no evidence of victims. Next slide. So yeah, in March 2017, the patient was asymptomatic, but then he was at the tune of around 4 years being disease-free. But then he developed some asymptomatic liver metastasis. So there were multiple liver metastases involving both the lobes. The patient was well preserved. The largest metastasis was 36 mm in the segment 8. Next slide. So we know that choosing the best treatment the first line is very important. Next slide, please. Next slide. So now I'll start with my panel discussion. So this is a case. I hope all of you have got a hold of this case. So if such a case comes to us today, so I'll start with Dr. Chandrashekhar. Dr. Chandrashekhar, such a case in 2022, patient treated with radical treatment, surgery followed by observation, did well for 4 to 5 years, and now the patient has come with the liver limited disease, but then right now disease is not resectable. Patient is asymptomatic. How do you decide such patients should undergo what all additional tests, as well as how would you take such a patient ahead?
Yeah, Dr. Sajjan, first and foremost, I would like to know whether this patient's HP specimen is available for testing for all the markers now, which is relevant for the decision making in the further treatment. If it's available, I think I would like to touch upon the previous block and then test for the markers and decide further. If not, then we may have to do a biopsy from the liver to look for all these things. Yeah.
Okay. So, Dr. Rumman,
Yeah.
If the biopsy block is not available, because sometimes 4-5 years patients are not able to get the biopsy block, the patient is amenable to biopsy right now. So when you do a biopsy in such a patient, so what all would you like to do? Will it be a staged markers, or you'll have a panel of markers which will suggest? So I'd like to have your insight into a liver biopsy done for such patients. So what all will you request in your histopathology as well as molecular pathology?
In this aspects, I think that liquid biopsy from the validated or CLIA 81 certified labs should be done. And in our country, actually only 2 or 3 are true labs available. They are doing liquid biopsy, but still now they have a lot of things to do. But I think that in India, there are lots of labs who can do confidently the liquid biopsy. If actually circulating tumor cell or ctDNA can be detected, and we do the molecular biomarkers from that ctDNA. There's the option. If the biopsy facility, actually, if biopsy cannot be taken from the liver as well, or any other particular sites.
Dr. Elaine, your thoughts on managing such patient? A patient has come to you at this stage of time. So what molecular test will you send? Whether you prefer biopsy is accessible for the patient is agreeing. So whether biopsy or a liquid biopsy, and what molecular test you will send, Dr. Elaine? Yeah.
We usually, since tissue biopsy is more accessible in our country, we refer to our colleagues in interventional radiology service, where they can do a tissue biopsy of the metastatic site if it's accessible. However, if the patient is not amenable to do a more invasive procedure, then we can offer liquid biopsy. However, that is more expensive in our country. For the molecular markers that we usually request, we start with the KRAS, the RAS, and the NRAS and BRAF and MSI if it was not yet done previously. And then eventually, if the patient is RAS wild type, we can also add, we usually add her to the panel. But that's usually the starting point for us: KRAS, NRAS, BRAF, and MSI.
Very valid points. Dr. Zilola, would you like to add something to what Dr. Elaine has elaborated? Some additional factors which you'd like to, apart from the markers which she mentioned? Yeah. Dr. Zilola, you are on mute.
In my opinion, in this case, I think that tissue biopsy is the best option. And second one, we can take biopsy from metastasis from liver, I mean, and so next we can just do IHC, you know, because for instance, in our country, it's not available for everyone to test molecular tests. So that's why we, first of all, I agree with Dr. Elena. She said that we can just IHC, we can just for KRAS, NRAS, BRAF, and MSI. It's available in IHC. And and start. I guess it will be enough for start first line treatment for patient.
Yeah. So, Dr. Sachini, so your take into a patient when you decide which molecular markers and which sample you prefer?
Sajjan, in Sri Lanka, what we do is, since it's several years after the primary, we would do tissue biopsy again and try and do all RAS mutation and MSI status, since it's very important. Failing that, we would go for liquid biopsy, which is not freely available in Sri Lanka. Yeah, I agree with, we have to do all RAS mutation and MSI status.
Okay, so I think almost all the panelists agree that these two are essential tests. So, so coming to Dr. Nikhil. So I can't see. Did we lose connection with Dr. Nikhil? So okay. So
Shubham, can you just check about Dr. Nikhil?
Yeah, because I'm not able to see him on the panel.
Yeah.
So okay. So I agree with you. Yes, liver biopsy preferably, because biopsy at this point in time will be more valuable, because not only we get kind of tissue which we're looking for, because sometimes even today liquid biopsies require a lot of standardization. They might not be always able to get all the mutations done. There's a lot of issues with the kind of content and quality checks. So wherever a biopsy is possible, always go for a biopsy, number one. Number two, I agree with all the panelists that the important markers are definitely pan-RAS testing, which include the 3 RAS, KRAS, NRAS, HRAS, and the BRAF. So these are important markers. Apart from this, one more thing which is important is MSI status, to know whether there is a predisposition for microsatellite instability. Apart from this, we at our center have been also using a broad NGS-based panel, because sometimes we end up having HER2 mutations as well as NTRK mutations, certain subset of patients, which might guide us with upfront therapy as well as subsequent therapy for such patients. So this is how we do it, and I agree that all of us are quite on similar page based upon where we practice. So I agree with you. So RAS testing definitely is a part of the guidelines across the ESMO, ASCO, everywhere, NCCN. We have been using RAS as one of the important, or a pan-RAS testing as an important tool, because that is very critical to choose the initial biological agent. Just one word, yes or no, about PD-L1. So, Dr. Chandrashekhar, do you get PD-L1 for colon cancers? PD-L1, Dr. Chandrashekhar?
Routinely, we don't do it. With emerging trends, I think if you happen to do a NGS, we prefer to do that. In that case, that we pick up that as well, instead of doing one after another. If we do a NGS, and I think most of the markers, even the unpredictable ones also, we can pick up. So that's where we are moving towards.
So Dr. Nikhil, we got you back. So can you hear us?
Sorry, sir. I just keep getting logged out and logged in.
It's fine. So
I agree with Chandrashekhar sir that most of us have tend to move on to NGS.
Okay. So before we move further ahead, so what is the kind of cost? So Nikhil, you'll have to unmute yourself, because there's a lot of background noise. I'm so sorry. So okay. So what is the kind of cost which you have to incur for NGS? So now Nikhil, if you could just take it, what cost you have to incur for NGS at your center if you send NGS? I would not say the best, but kind of an Indian.
So the Indian cost is somewhere around 40,000 on a more or less similar scale. But then there are so many coupons and so many substitutes available, wherein even if you have a non-affording patient, we can just manage it somehow. Its cost is usually not an issue.
Okay. So Dr. Sachini, at Sri Lanka, what is the average cost? Like, for example, if I had to compare this in US dollars, so in India, it's I would say very easily available in the tune of $500 to $1,000 we are able to get a decent next generation sequencing test done. So what is the kind of situation at Sri Lanka?
In Sri Lanka, we don't have PDL1 OMSI status freely available. So we used to send it to either India or Korea or Singapore. So then it's very expensive knowing that the transport cost and nowadays due to COVID. So it's, I would say, it's more than 3 times the cost that the Nikhil told. Yeah, it's very expensive when we do. So we choose very carefully the patients. That's why I told like the grade 2, the borderline patients we used to do practically. Otherwise, I agree that we need to do it to everyone if they can afford.
Okay. So, Dr. Chandrashekhar, what is the condition in Malaysia for any NGS test? So, a decent NGS test, what is the cost in US dollars in Malaysia?
Basically, the companies which are involved in doing all these molecular testing, they send the samples overseas because in Malaysia itself there are no labs which are doing it on site. They send it, and then the turnaround time is about 7 to 10 working days. I think, which is reasonable enough. And then the cost was quite high in the beginning. It was about 4 to 5,000 USD, and then now it has come down to almost around 1,000 USD. Yeah? So a lot of players coming in and then being competitive. The costs are coming down, and then which is a good news, so that we can convince more patients to be tested for all these things. We try to push patients for instead of IHCs for individual markers. If we do the NGS, I think we pick up many more things other than what is being standard at this point of time. Yeah.
Dr. Kamruz, at Bangladesh.
Yeah.
Because Bangladesh has been very, I would have, we hear a lot of good news about Bangladesh. Everything is being like we have made in India, now we have made in Bangladesh. So, it is a pioneer in oncology drugs. So, is that with the NGS also at your country?
Actually, I want to share my experience. Actually, in some extent, especially in the pharmaceuticals industry, we are rising. It is no doubt. But actually, for doing molecular biomarkers, actually, we are a little bit backward. At current facilities, we have 3 labs. Those are actually doing the only targeted biomarkers, like the single-based biomarkers, like the KRAS, NRAS, and EGFR or PDL1. Actually, common 5 biomarkers for the colorectal cancers are available individually, and it costs around, and it is only based on RT-PCR based, but not the NGS based. Commercially available now. The 2 labs are available. 3 labs are available. They are doing RT-PCR based biomarkers, and cost is individually, as for example, KRAS, only for KRAS is 15,000 Bangladeshi taka, like the Indian rupees 10,000 rupee. Okay, if we want to 5 biomarkers, then 50,000 Indian rupees, approximately, for example, 500 or 600 US dollar. And for the reasons, actually, I felt very, I was eager to do some NGS-based panel. For the reasons, actually, I developed my own idea that we should do NGS-based biomarkers as early as possible. And 2 years back, I proposed a plan for developing NGS-based biomarkers like Kaizen, from the Kaizen kit, 51 gene panel based biomarkers. We are hoping, we are just near to end of this my research. We did a 51 gene panel along in collaboration with the North-South University, and it is funded by the Planning Commission of Bangladesh. I hope that the cost will be approximately 500 to 600 US dollar. We can do the 51 gene panels.
I think that's a great initiative, Dr. Rumman. So I congratulate you for such a great initiative. And now we move to Dr. Elaine. Dr. Elaine, what kind of a cost you incur for NGS, kind of a decent NGS panel which covers almost all actionable genes at Philippines. What's the cost in US dollars?
Usually for the like in Bangladesh, the KRAS, NRAS, MSI, PDL1, BRAF testing is available in some hospitals in the Philippines. It would cost about 1,500 US dollars. The comprehensive NGS usually costs about 4,000 to 5,000 US dollars in our country, but one company offers a discounted rate, so we get it for about 2,000 USD.
That's very nice. Dr. Olimova, at Uzbekistan, what's the kind of situation?
In Uzbekistan, unfortunately, situation is not so good. But you know, we had a discount from foundation approximately 2 years during the pandemic, and that time NGS whole genomic test NGS was approximately for that time 1,500. Now it's more expensive, 2,500. But recently we start to work with Phobes Care. For instance, today I received new results of metastatic colon cancer, and it's approximately 900 for NGS, and sometimes we send to core lab in India, so it's patients available to pay. So we just ordered just some and send to India's lab. But we can do in our lab in Uzbekistan only IHC. So sometimes when it's not available for patient, we just can use IHC immunochemistry for MSI or PDL1 or PD1, just to and BRAF mutation, BRAF V600 mutation, which available in IHC, but for NGS, we just have to send to India, Germany, America, and etc. So, but soon government, we will organize, we will win a grant, and probably soon we will start in the government hospitals, oncology centers, do NGS, and we were waiting for that. So
yeah. So the kind of message which I would derive from talking to all of you is that yes, we all have been using NGS or some form of molecular testing in the form of RT-PCRs, complex PCR panels to at least have important treatment decisions made. And we're also moving towards a more economical kind of NGS, which is available to us in the range of 500 to 1,500 US dollars. So that's very heartening to know, because I think over the next 2 to 3 years, we'll have more NGS panels coming to us, and these test rates going down with more clinicians using these panels, because it all depends upon the kind of samples, the number of samples the lab processes every batch. So if these initiatives are adopted by oncologists, and more oncologists are using these panels in their practice, in fact, that will help the companies reduce the cost and make it more accessible, and also decrease the turnaround time. So normally, if you are at a high volume center, it is not at all, I would say, impractical to not get reports in 5 to 7 days, even for NGS, because it all depends upon the kind of volumes you are treating. So with this message, we'll go ahead with the case, and can we go to the next slide, please? Next slide. So we now know that these we already discussed, and across all countries we have this guidelines where we have pan-RAS testing, which includes BRAF. Next slide, please. And MSI. Next slide, please. Can we scroll down? Can we scroll down further? So this we already discussed. Yeah. So all these are guidelines which we have seen that across various Asia Pacific, European as well as US guidelines, these markers have been part of our management. One more thing which has come up quite very recently, I would say last 6 to 7 years, is to know the sidedness of the tumor. So I'll start with Dr. Chandrashekhar. Does the side matter for you? Whose side are you on?
I think with the emerging data, I think it is important to consider because it's not a cost effective way to look at it. You just have to know which side of the tumor it is, and then you can have the good prognostic implications depending on the site. I think it's very easier to know this, and then data is coming up. I think in a short period of time, it will be validated, and then a lot of promising findings are seen from the many studies and then meta-analysis that the prognostic significance is there depending on which side of the colon the tumor is situated, and then directing the treatment accordingly will be a good step forward, I think.
Yeah. So Dr. Sachini, right is not right. So do you agree? Something wrong with the right.
Yeah, in my experience in Sri Lanka, we do have a lot of poor prognostic patients in right-sided colorectal cancer, especially when they presented with mucinous adenocarcinoma. So they do poorly. Than like we can start first line, second line, but they do initially respond very well, and later in 1 year time we get metastatic disease, peritoneal metastasis. So the right-sided, obviously with our experience, gives poor prognosis. So we do consider the sidedness as a prognostic factor.
Yeah. So in fact, the prognosis is hugely skewed towards more of left-sided tumors. The progression-free survival can be as high as 3 times in the left side compared to right-sided tumors. So, Dr. Elaine, so apart from the side, what are the other factors which have a huge bearing upon your patient's journey? So we understand side is very important because side is kind of a surrogate marker for the kind of genetic profile that patient can have. But could you just elaborate some more prognostic markers which you take into consideration, which you feel are important, Dr. Elaine?
So aside from the side and the molecular markers that we request, of course, we discuss with the patients all the treatment options that are available and check the patient's characteristics and which treatment will be best given to that specific patient. So a patient preference also comes into play if the patient wants to, undergo treatment every 2 weeks, every 3 weeks, be admitted or do it in an outpatient setting, the comorbidities of the patient or the medical condition of the patient, and also the performance status of the patient, if the patient can receive a more aggressive regimen or the patient can just receive really palliative chemotherapy. And of course, the goal of treatment has to be presented at the start and has to be explained thoroughly and discussed thoroughly with the patient.
Yeah, I totally agree. So all these factors are so important. So what is your, I would say, as a niche physician, what is your goal towards when you're treating? Even at metastatic patients, you will have 3 subset of patients. One patient will be potentially susceptible disease, will be very aggressive with those such patients. Other will be unsusceptible, but younger, fitter patients, your management will be different. And third will be elderly, frail patients, where your management will totally be different, and you might have to really decide what are the goals. So, Dr. Zilola, any fascinating role of this microbiome? So you have certain signatures or something like that. Are you aware of certain microbiological or signatures of colon? So is there a role of microbiome?
Oh, no.
Okay. Dr. Nikhil, are you there? Because I can't see Dr. Nikhil, but I could ask Dr. Yes, Dr. Kamruz.
Yeah, actually, I think you are absolutely right. Still now, there are lots of studies. I found few of them. Actually, they prove it that the metagenomics can, in near future, I think that metagenomics will explore a lot in respectives of the metastatic colorectal cancer. Obviously, there are lots of studies already. I have seen studies from the China and other. Also, I have not found in any meta-analysis, but individual studies, they proved it that there are lots of relations of the microbiota, gut microbiota for developing the colorectal cancer carcinogenesis or just metastasis property. And I have a future plan to do metagenomics from my actually samples for searching such type of associations.
Yeah. So like we have signatures in colon, like in breast cancer. Now we're also having molecular signatures which are specifically different from others. So like we have basal-like or HER2 enriched, or for example your ERPR kind of markers which we have in breast. Similarly, we also have molecular signatures in colon, which is CMS1 and 3 are molecular signatures which are poor prognostic, and CMS4 and 2 are relatively better prognosis. So that kind of a role also is coming up with a lot of these genes being involved, and also microbiome is also a part of the kind of the bacteria which are responsible, which could have a bearing upon a person will develop a right-sided colon cancer or left-sided colon cancer. Really fascinating, and I agree that in the near future we'll have these also as part of treatment decisions. So next slide, please. Next slide, please. Next slide. So this patient was found to be pan-RAS wild type, BRAF wild type, and MSS. So I will come to Dr. Sachini. So a patient, now we already have this history. How would you manage such a patient? Patient has got multicentric liver disease, right now not resectable, no other site of disease. So patient is around 65 years. So how would you manage such a patient in your practice?
Sajjan, we assume that patient doesn't have comorbidities and fit to accept the systemic treatment. And if after the discussion consent and if all the facilities available, I would do NGS, the next generation sequencing, and with this the wild type results, I would start FOLFOX plus cetuximab first, and give 2 weekly 12. I mean, it's the day 1, day 15, 6 cycles with the available clinical, radiological, and biological markers. I would do response assessment, and we'll try expecting the disease. Usually, in my experience, the metastasis disappears after the 6 cycles, day 1, day 15, complete 6 cycles. Radiologically, the metastatic macroscopic disease disappears. So that's the experience, and that's what I would do in this patient.
Okay, Dr. Chandrashekhar, your inputs into a patient. Though
Yeah.
this patient had multiple comorbidities. I had mentioned this patient had diabetes, hypertension, BPH, was on treatment. So if a patient, like it's like I would say real life patient at 65 years of age has multiple comorbidities well controlled. So what is your choice for such patients? One is the choice of biological.
I think age has become just a numerical value in the present scenario. I mean, we don't go by the numerical value of the age. We look at the patient and then assess the patient's status. Of course, he has a comorbidities like diabetes and then the hypertension and then the prostate problem. Everything is under control with the proper medications for that. I would consider this patient is fit enough to go for the intensive therapy to begin with, first line. The best is to be offered in the upfront. That's what I believe in. And then this patient is having a wild type for all the markers and then the MSS. I would go for the cetuximab with either FOLFOX or FOLFIRI after discussing with the patients, like the profile of side effects. In Malaysia, what is important is the patients want to know what kind of a side effects they have. Generally, people don't like the GI side effects here. So we tend to go towards the FOLFOX rather than the FOLFIRI. A lot of Chinese patients, Malay patients, they don't want to have the GI side effects. To some extent, they will accept the neurotoxicity. So most often it is FOLFOX. Yeah. I would prefer FOLFOX with cetuximab with a given information at this point of time.
Very nice. I take your points. All these things are important discussions with the patient, especially when once we're deciding which are the drugs and what possible side effects they could have, and also whether they are in sync with the socio-biological population's needs. These are important. So, Dr. Elaine, will you go for cetuximab plus FOLFOX, or you have any other different choice, and why?
You actually have the same option here in our country. Since the patient is wild type for RAS and BRAF, we give an anti-EGFR therapy, and so we can give cetuximab plus either FOLFOX or FOLFIRI. If the patient has some neuropathies from diabetes, then maybe I'll just give FOLFIRI.
Yeah, I think I agree with you. So, Dr. Rumman, the patient is diabetic, diabetes uncontrolled, patient has neuropathy, patient also has some degree of gastric or I would say intestinal involvement with the diabetes. Such a patient, what would be your preference? Yeah, your inputs.
Yeah. Actually, my suggestion is that as already patient have uncontrolled diabetes mellitus, there is still a chance of chemo-induced neuropathy more severe with the additions of oxaliplatin. So I will prefer the irinotecan based, that means FOLFIRI and cetuximab would be my treatment of choice.
Okay. Okay, I'll come to Dr. Sachini. What is your take with in your clinical practice, you use cetuximab more common, or you interchangeably use this with the bevacizumab or panitumab? So these are other two options. And how do you decide for which patient you'll use bevacizumab, which patient you'll use cetuximab in same setting, like this patient, which patient you'll offer metastatic patient 65 with some degree of control for diabetes. So bevacizumab versus this EGFR antibody.
So it's a very tricky question, Sajjan, but still in real practice, what we do is by considering the risk of like knowing the same genetic panels, I would prefer cetuximab, knowing that I have experience with good results with cetuximab and upfront first line chemotherapy. However, if there are peritoneal fluid, but this patient doesn't have, but if hypothetically, if the decision-making point comes, I would consider that fact when the ascites. So in my experience, the patients with ascites do better with bevacizumab. However, in this patient, I would not think of starting bevacizumab at this point. The first line chemotherapy, FOLFOX or FOLFIRI plus cetuximab would be my first choice.
Okay. So, Dr. Zilola, any specific patients for VEGF inhibitor? Like, I really agree with Dr. Sachini that certain patients who have ascitic form, patients where you think that the VEGF switch might be on. So that's one subset of patients. Probably the patient was not medically fit to be operated, and the patient will not be ever a candidate for surgery. So the disease is unresectable. So will that change your decision to use the biological agent or sequencing? No, Zilola.
For sequencing, yes. In this case, honestly, I prefer more FOLFIRI and cetuximab, as before mentioned our colleagues, because he has a diabetes and hypertension, and that bevacizumab common side effect is hypertension, so I prefer here more cetuximab, and after 6 cycle of chemo and cetuximab, maybe he will become operable, and and the NGS exactly. In this case, so if we will have some progression of disease after 6 cycle or several cycle of chemotherapy, maybe we will do NGS again. So I recommend.
So I agree with all the panelists. So the preferred choice which I can get from the panelists is that they will go for an anti-EGFR antibody preference over a VEGF antibody, and their first choice of chemotherapy is more likely to be Folfox. If there are no pre-existing neuropathy or uncontrolled diabetes, something like that, then they are likely to use this arm. What my inputs will be that yes, I agree that in many of our patients will be using this combination. However, once if the patient we know that patient is not going to be resectable, and then we really don't know which is the sequence which is better. We could also interchangeably use bevacizumab plus Folfox as one of the starting point, and then switch over to anti-EGF on the second line. Then also we are not wrong, because now we have data from ECOG and the large NCI data, the collaboration, which found that either way it is good. However, it is more wiser to have, I would say, we have more robust data with cetuximab being used with FOLFIRI, because that if we are wanting certain response rates, for example, it's only liver limited disease, it's a 65 patient, I would like to make it resectable, then I might be more inclined to use cetuximab plus FOLFIRI versus cetuximab plus only Folfox, because there are certain negative trials which have used cetuximab plus Folfox, and they're not found to be useful. Large trials where they do not show any major benefit of cetuximab with Folfox, but then yes, there are positive trials too, where response rates are not that great or they're not needed, and we only require progression-free survival. I think both the chemotherapy arms might be good. Now, the same patient would have come to you with a right-sided tumor. So how would your preference change? So I will go from Dr. Chandrashekhar, right-sided tumor. Patient did not have a left-side tumor, right-sided tumor. So what would you do for such a patient?
I think with the limited data available with regard to the side of the tumor situation, location, and then the prognostic indication of the site, probably I would choose the bevacizumab with the chemotherapy.
Okay. So, Dr. Rumman, will your treatment change with the side, or you are like, I can use it interchangeably, and whenever the disease progresses, I can switch to? So same patient, wild type, everything wild type, MSS, and then right-sided tumor. So what will be your choice?
Okay. Still, if everything is wild type tumors, then actually my choice should be again. I think that cetuximab or panitumumab along with intensive chemotherapy, either Folfox or FOLFIRI.
Okay. So, Dr. Elaine, any difference of thought from Dr. Rumman?
There's a study that was done before saying that right-sided tumors respond poorly to anti-EGFR. So I might be more inclined to give bevacizumab, because it was compared bevacizumab and cetuximab in right-sided tumors, and it was found out that bevacizumab has better overall survival in right-sided tumors as compared to left. Sorry, as compared to cetuximab, rather.
Okay, okay. So we get your point. Dr. Sachini, your thoughts on right-sided tumors?
When it comes to right-sided, even with the available data plus my experience in Sri Lanka, the right-sided tumors do get peritoneal metastases very often and very soon. So the progression-free survival, like the treatment option always, I would think of vascular endothelial growth factor inhibitor if it's positive, and I would treat with first-line chemotherapy for Folfox or FOLFIRI, depending on the comorbidities, plus bevacizumab than cetuximab, since there are evidence, as Dr. Elaine said, plus it's my experience, it works well, the bevacizumab and first-line chemotherapy for right-sided tumors.
So, Dr. Zilola, suppose this patient was right-sided, was RAS wild type, but the BRAF was muted. So, would your treatment change in certain, and the patient was relatively fit. So the age was just a number. Though the patient was 65, he looked like 55. He's from Uzbekistan. He's a fit Uzbek guy. So how would your treatment change if the patient is BRAF mutated, RAS wild type, and MSS?
There are a lot of data that in that case more beneficial will be triplet plus cetuximab triplet. Or
So you would like to say that something like FOLFIRINOX or
yeah, FOLFIRINOX, yes.
FOLFIRINOX. Okay.
Yeah.
So
FOLFIRINOX.
Dr. Chandrashekhar, your thoughts on this subset of patients which are they are actually younger patients who get BRAF mutations. They are wild type. They have MSS. They are right-sided tumors. So how do you manage such patients?
Yeah, okay. I think that the prognostic factors plays an important role here, and then the metastatic potential to the multi-organ involvement and all that, and then depending on the site. So if all the markers are available, and then it is a right-sided tumor, like if patient's general condition is better, then probably would consider using the triplet. Although the toxicity profile is a little bit higher. But if you are looking at the resectability at a later date, then I think the better R0 resections are feasible with the triplet FOLFIRINOX with the cetuximab or anti-EGFR.
Okay. So now I'll come to Dr. Rumman. For example, this patient was a left-sided tumor. Initially, we treated with the cetuximab plus FOLFOX combination. Patient did very well with the combination. We could resect the disease. Okay, the resection was possible. So after 6 cycles, resection was done, and then you find the CE is absolutely normal, no disease anywhere. So how do you treat such patients beyond resection?
Okay, thank you. Actually, as initial response was very satisfactory. So I think that yeah, I do agree with your presentations that cetuximab monotherapy may be continued for some duration. Then if the disease relapse, then we need to consider or newer things, or we need re-biopsy or NGS-based further molecular assay, whether is the pathway is little bit changed, so that we can do further planning. But in my planning is that continuation of the actually maintenance therapy with cetuximab, if the initial response is very satisfactory.
Okay. So we assume that this patient completed the 6 more planned cycles, and then we stop the treatment, and then we decide to follow this patient up, and then the patient again comes with metastasis. So can we go to the next slide, please? Next slide. Next slide.
Yeah, Dr. Sajjan, can I add something here?
Yes, sir. Yeah, please do that.
Yeah, I mean, why I would like to use the bevacizumab in the right-sided tumor is like, even if you look at the data from the CLGB trial 80405, I think the bevacizumab has favored over cetuximab because the overall survival was shown to be slightly better there. Yeah.
Cetuximab.
Yeah. So in fact, if we just go through
bevacizumab is favored there. Sorry, bevacizumab is favored there.
Though there are a lot of subsets and a lot of debates still going on as to which is a better sequence, but I will say in the subset of a population which is left-sided EGFR positive, if you just see that through the meta-analysis, they do much better if the sequence is EGFR along with FOLFIRI or FOLFOX and followed by BEV with FOLFOX or FOLFIRI. But yes, I agree. If you just see the overall population, I would say BEV plus FOLFOX is good. So we don't really have the right answer. But then if we look at too much, then we might have this some kind of insight, but then we don't know the right answer.
Currently we are in a gray area, I think, that it needs to be addressed.
Yes. So for example, this patient, we did well, patient underwent surgery, treatment completed on follow-up. Now the patient has come with extensive metastasis after 1 year. Okay. So 1 year, the patient was off treatment. Dr. Rumman was treating him. He said, okay, don't worry, you are fine. I'm giving you 1 year of break. and after 1 year, when the patient comes back, a lot of disease in the liver, in the lungs, in the tummy. So beyond the first line, the patient is still EGFR positive. So now, and one more thing which I feel is that the patient has become BRAF. There's a mutation in the BRAF. So, Dr. Zilola, I'll come to you. Such patients in your settings, how are you managing such patients?
If BRAF mutation positive, right?
Beyond first line.
Yeah.
Beyond first line. Okay. Maybe triplet I've already used. So next maybe will be, oh my goodness. So, you know, in my case, for instance, I use triamcinolone, and bevacizumab in that case. I have a response, and so I use third line of chemo. So because this exactly in this patient, this patient has a diabetes, hypertension, and that time I guess it's best option, and I had good result. Maybe 2 or 3 patient uses him, but with not bad results. So it's my opinion.
Okay. I think it's a very well point, but yes, BRAF mutations are different from lung, and we need to see what kind of a BRAF mutation is happening here. But if it is V600E, then we can use the combination of Dr. Rumman, you would like to add something here? Yeah.
Yeah, I want to add that as there is already disease progressed, and actually the tumor expressed the BRAF mutation. So we need to use the, and actually BRAF inhibitors are just like encorafenib along with cetuximab. Already NCCN guideline already recommend this.
Yes. So Dr. Sachini, the patient was found to be MSI high in the beginning. So patient is MSI high, and you got pan wild type, everything else wild type, MSI high. So what do you do for such patients in the first line setting?
I would discuss the place of immune therapy with the first line chemotherapy, knowing that it's very expensive and not freely available. However, would have the discussion with the relatives to add first line plus nivolumab.
So you use nivolumab as along with chemotherapy. So
yes.
Okay, very nice. So Dr. Elaine, does monotherapy work enough for MSI high, or you like to add chemotherapy either to nivolumab or pembrolizumab? So what is your practice, MSI high patients upfront?
For MSI high patients, I'll give immunotherapy with chemotherapy.
Okay, very nice. So you are also more inclined to use chemotherapy with immunotherapy. Dr. Chandrashekhar, yeah. Any comments on?
I think the panelists. Yeah.
So now we understand that even small tweaks into the molecular pathology can have a huge impact upon how we are treating such patients. Next slide, please. Next slide. So meanwhile, I'm getting a lot of questions also. So I'll take some questions here with the permission of the organizers. So we can ask these questions from our panel. So there's one question that it is clear that based upon this, cetuximab-based therapy is preferred, and if the patient was pan RAS wild type, but if the patient has PIK3CA or SMAD4 alteration, how would you change your treatment? So this one question from one of the panelists. So could I ask Dr. Rumman, would you be happy to answer this question? PIK3 mutation.
PIK3 mutation. Actually, I have no experience like this PIK3 mutation. Actually, I cannot give any clear idea.
Okay. Yeah. So Dr. Sachini, any patient with PIK3CA broad-based NGS was sent, PIK3CA being a part of this, it's a downstream pathway. So does that change your management? Because like we understand BRAF definitely changes our management. We know that if BRAF is mutated, sometimes adding cetuximab might not really even work sometimes. But if BRAF is BRAF inhibitors are given along with cetuximab, then it might work. So does it really change something for you as of now, Dr. Sachini?
No, I don't have experience with PIK3 mutations, as we don't do it often.
Okay, so I'll put my comments as of now. We're not changing our practice based upon these mutations in the front line, but yes, beyond 3 lines of treatment, if the patient continues to have these kind of mutations, then we could explore PIK3CA inhibitors into our practice, because we have standard 3 lines and beyond that, definitely they become important for us. One more question by one of our attendees, Suma MN. So they're saying, why immunotherapy in colorectal cancer is based upon MMR and TMB rather than PD-L1? I think very, very beautiful question from this ma'am Suma. So Dr. Sachini, everywhere you're talking about PD-L1, and here we are talking about TMB and MMR. So what as an oncologist you feel about PD-L1 here? Do you feel something about PD-L1? Why don't we get PD-L1 here?
Yeah, that is very important in this. Then when the patient recur first line and second line, I think PD-L1 is important to decide what kind of a targeted therapy that we can use, and whether it's worth using, because it will give us prognostic indicators as well, whether worth spending such a lot of money. Nivolumab, pembrolizumab, very expensive, so that will give us a prognostic outcome of the patient.
Okay, so I'll put this question to Dr. Elaine. Why not PD-L1 for colon cancer, Dr. Elaine?
I guess there are more data on MMR and MSI testing on colon cancer and PD-L1 testing for other types of malignancies as compared to colorectal cancer. But as to why, I am not really sure why.
Okay, so I think the oncologists are right, because when they tried to do phase 2 data with PD-L1, that did not work. So they, the companies who are running drugs like nivolumab, pembrolizumab, they try to find biomarkers in all malignancies, and when they try to get PD-L1 based phase 1 data, they were disheartened. But when they tried that such analysis, and then they found that, okay, the patients who are MR, there was a big trial which had all comers in the stage. It was a phase 1 trial, all comers, MSI high. They found that pembrolizumab worked very well for such patients, and then from there they took MMR as one of the markers. PD-L1 failed miserably as a biomarker for colon cancer, though still it is there in head and neck cancer, lung cancer, but it does not work for colon cancer. I don't know the answer honestly, but then a lot of questions sometimes are still to be answered in the future. So one more question I'll ask Dr. Rumman. So
yeah, I want to.
Yeah, Dr. Rumman, TMB.
Yeah.
So what is the prerequisite for TMB? So do all NGS can do TMB, or there's a specific requirement to get TMB done?
I think that more validated actually protocol or research should be done for TMB. At present, TMB actually is not available in Bangladesh. Hopefully in near futures we can do TMB here. My actually addition according to your query is that if in case of, although there is no actually data in favor of actually if the only MSI is high, then we can add the nivolumab or pembrolizumab. But if in this such type of case, after completion of the 3rd line or 4th line therapy, if the tumor still expresses MSI high, TMB high, and also more expressions of the PD-L1, then actually I think that my idea is that then actually we can add the pembrolizumab or nivolumab, although these drugs are too much costly. Maybe in near future, I think that lots of study are awaiting, and we find the result.
Okay. So I will add, yeah, so I will add to your answer. So TMB is one concept where we try to find what is the level of the tumor mutation burden per the MB of DNA. So there has to be an adequate number of DNA being tested. So on average, if NGS panel does not have 200 genes being analyzed, then it is insufficient to get you TMB data. So that's one thing. So most panels which have at least 200 genes being evaluated are the panels which can give you true TMB data. And also there are a lot of confusion with respect to cutoff. So should we have 16 MB basis per 16 mutations per KB of a DNA or eight basis base pairs? So that also is still controversial and evolving. But yes, if you need to get TMB, I think the best tests are like Dr. Elaine mentioned about Clarivis or Foundation One or Paradigm. So there are big NGS panels which involve a lot of genes, at least more than 200 genes, are the right panels where they can give you some information about TMB. So the Dr. Suma is a pathologist in the audience. So I hope that we'll be able to answer some questions from your side. So there's one more question from Mr. Abhishek Roy. Does this biases of gut microbiome accelerate the CRC process? And does it alter with age, and what features, is it right-sided or not? So I'll try to answer this question for you. So the microbiome is very evolving, and we understand microbiome also depends upon the underlying gut pre-existing comorbidities like Crohn's disease or kind of ulcerative colitis. They have a huge bearing upon the microbiome there. Also, somebody who has been throughout a red meat eater versus somebody who's a vegetarian, their microbiomes are different. So there are multifactorial differences in the microbiome of various people. So this field is evolving, but very interesting. So it does not only affect the right-sided colon cancer, but the left-sided also. And the microbiome decides how over time the kind of mutations which will accumulate in the colon and which can lead to cancer. So I'll take 2-3 more questions because there are a lot of questions that are coming from the audience. So there was one question I'm not really able to understand this question. This is by Juwaria, and it is that the person is curious with cellular marker which would prefer to look in a spatial context. If you can get the spatial information of the biopsy. So I think yes, tumor heterogeneity is there. Certain times, if you're only accessing the circulating tumor DNA, you might miss out upon some of the mutations, and that's why a good tumor tissue biopsy is required, especially to have more tissue and to have decreased tumor heterogeneity, and spatial arrangements can be sometimes important to either identify or miss these mutations. So these are some questions in the audience which I've been trying to address. I'll be happy to have more questions. We have around 10 more minutes of discussion left with us. So now I'll go to Dr. Sachini. This we have already answered. Can we go to the next slide, please, Dr. Sachini? So about the sequencing, we have had trials like FIRE3P, CalGB, and SOC data being analyzed, which found that yes, if the patient was a left-sided tumor and the first-line EGFR was better than not using an anti-EGFR, and it was better when they do a kind of a meta-analysis of these trials, they found that using EGFR followed by VEGF antibodies in these patients better. Next slide. So I just quickly go to all this data shows that patients who are first subjected to EGFR were likely to have better objective response rate. Next slide, please. Next slide. So, Dr. Sachini, role of panitumab. Do you use panitumab in your trial, in your practice? Is panitumab available, freely available to your patients? And is there a choice between these two agents, panitumab?
No, Sajjan, it's not freely available in Sri Lanka. So we don't often use panitumab as the treatment option for our patients.
Okay. So in India, we have been interchangeably using panitumab compared to cetuximab. So panitumab, though it has got sometimes its rash being a nuisance value, certain times and sometimes GI tolerance might be issue. But then if I compare to cetuximab, it is more better tolerated compared to cetuximab. But then with cetuximab, we have larger data, we have larger number of trials which have happened. Big phase 3 trials have happened with cetuximab. So most of the clinicians end up using cetuximab compared to panitumumab. But yes, if some of the clinicians would like to use panitumumab, they can definitely use. I would say both the drugs are quite interchangeable. Next slide, please.
Sajjan, I have a question. Like, what is the cost factor, like the panitumumab and cetuximab?
So in India, the good thing is that the panitumumab has been made accessible to us through Dr. Reddy's, so which is a Indian company, and it is at par with cetuximab. So a dose of panitumumab costs something around $2,000 to $3,000 US, and that's the kind of cost which we have also with 2 weekly cetuximab. So cost-wise, both of them are similar in India.
Thank you.
Okay. So we have one more question coming from our Mr. Pramod has asked that very useful discussion. The cost of NG seems to be common constraint. I think that's a comment, and definitely we'll share that discussion across all the nations and makes us understand that NGS is a part of our kind of routine practice. And there was one more comment where do we use comprehensive genomic paneling in our CRC patients? Given a choice, in all my patients, I'm sending CGP at the beginning. But yes, if I have to wisely choose, I do pan-RAS testing and MSI testing in the upfront setting, and then subsequently I use HER2/neu or a more broad-based panel or a CGP beyond my first line. So that's my answer to this question. So can we go to the next slide, please? Next slide. Okay, so yeah, this I'm on. Yeah, go to the next slide, please. Next slide. So this we have already used. So are these interchangeable? I would say yes, they're interchangeable based upon where you are practicing, and we can use any one of them. Next slide, please. Next slide. One thing which is slightly better with cetuximab is that there are a lot of off-target events, and there's NK cell activation which happens with cetuximab because it's a chimeric antigen, whereas panitumumab is actually more of a purely human monoclonal antibody. So that additional NK cell activation, macrophage activation happens more with cetuximab, and that's why it also leads to more of side effects compared to panitumumab. But yes, that might be one of the reasons why probably it might be more responsive, but that's not a sure shot, I would say, of treatment decision between these two drugs. Next slide. This we have already answered. Both are interchangeable, but then we have more data with FOLFIRI with cetuximab compared to FOLFOX. So if I had to use bevacizumab, I might use FOLFOX more often. Wherever given a choice, I will use FOLFIRI along with cetuximab, especially if I'm looking for faster responses in my patient. And I might also use triple drug combinations with like FOLFOXIRI along with cetuximab, especially with liver-limited disease, where my aim is to achieve a kind of a complete pathological response in my patient. Next slide. Next slide, please. We have already discussed these data. Next slide, next slide. So this we already discussed that triplet might be useful, especially to maximize the objective response rate, conversion to resectability, and OS and ROS wild type metastatic colon cancer. In fact, there's data where this led to a 48.5 months median overall survival in the selected population. So this would be really fascinating. You should always use these drugs, especially in fitter patients. They might have a huge impact upon the median overall survival. Next slide. Okay, so I think we have had almost I would say more than 1 hour and 15 minutes of discussion. So I would like to engage now Dr. Vidya. Dr. Vidya, you can pitch in. It's been really heartening to have you here, and then you could moderate some of the questions if you have from your side. And from my side, I think we have had an extensive discussion on the first line, second line, and beyond second line.
Dr. Sajjan,
Yes.
there's a participant who wants to engage in a discussion.
Yeah, please
through
go
a
ahead.
voice mode.
Sure.
Shon,
Sir,
can you
please,
unmute?
please stop sharing the screen?
Yeah, you can stop sharing. I think next 10-15 minutes we'll just have question and answer to all the panelists or to me, whichever way. So that will
Shubham,
make
can
it
you unmute Dr. Maqsood? He has raised his hand.
Dr. Maksud, yeah, you have to unmute. Yeah, he is unmuted now. Dr. Maksud, please go ahead.
Hello, doctors. I see here is collect all around the world, all the oncologists. Nice to meet you, and it's my first time at attending this meeting. And I want to talk about there is what's the reason of the divide the left side and right side if you have already the mutations, RAS and RAF mutations, and also the other NGS informations, and is there any role of dividing it left side or right side? I want to ask there, and that first time there is if there is a wild type that by all the informations, all the trials, it's a wild type. The EGFR anti-EGFR blockers is very, say by the trials is better than the anti-VEGFR blockers. And I want to talk these ones, and I want to meet with you. And that if you are allow me, the next time I want to join with the discussion also. I want to share my minds also. Thank you.
Yeah, sure, Dr. Maksud. We will definitely take this up in the right platform in the coming panel discussions. Thank you so much for that offer.
I'll just add to the what point you raised. You're right. In fact, for so many years we didn't know how right-sided tumors differ from left-sided tumors, but then now we understand that the gut is, again, it's a large tubular structure. So if you start from a small intestine, so small intestine is the largest part of the gut, but still we find that tumors are so rare, very rare tumors to happen in small intestine. We don't know why. So same way, certain questions we don't know the answer, but then probably when the stool is getting passed from the various areas, the kind of carcinogenicity of the ingested things or the kind of stress the gut has is probably different on the right side, and by the time it comes to the left side, because even embryologically these two areas are different. If you just see embryologically, these two areas are different. So till ligament of treats, there's one area, and then beyond that the other area is actually the hind gut. So the kind of embryological differences could be possibly resulting into different mutation types, but that is a possible explanation for why right-sided are different from left. But then this concept has only evolved in the last 5 to 7 years. Before that, so many papers never mentioned this, and they took colon as a whole. So I think that's very fascinating. Somebody like you would have observed that yes, they are different and they should be treated differently.
Thank you.
Any other questions you could put in the chat box, or you could unmute yourself, or Dr.
I have a question for all of you.
Yes.
In your routine practice of comprehensive genomic profiling and its application in CRC management, particularly metastatic CRC management, how often you felt that doing an MGS upfront would help you in taking better decisions? Rather, instead of NGS, let me put it this way: you look at all the important biomarkers like RAS, KRAS, NRAS, BRAF, HER2 amplification, and then TMB, MSI, and of course the other prognostic biomarkers, which are not very well established, I would say. Like in this case, people asked about SMAD4 mutations, PTEN mutations, and all. These are there, but then they are not very well established in terms of large scale studies, that these markers would never come as part of the standard of care guidelines as of today. So having said that, if you look at, let us say you have a CRC patient, metastatic presentation, do you think looking at a complete molecular workup would help you in taking better clinical decisions in terms of the choice of therapy in the first place?
Dr. Vidya, I agree with you. Yes, a comprehensive genomic panel. The only issue is accessibility. I just mentioned, because if it was accessible and affordable, it would be a part of the initial treatment decisions, and there's no harm in getting a CGP done at the beginning. I would say yes. I'm always, I would say, agreeable for having a CGP. It gets us more information on the molecular level, so that I can take better clinical decisions. But if accessibility is an issue, then we have to go for what is available to us. Number one. Number two, I also understand that certain mutations are rare, and then they might not change the first line management, but yes, second, third line, they definitely make an impact for us. So one more thing, we had some more questions, like Mr. Anil Kumar has mentioned that immunotherapy, is it in practice in India? If yes, then why is it difficult to treat CRC with immunotherapy? So immunotherapy is routinely being practiced. There are a lot of immunotherapy drugs which we are using in our practice. It's a part of the routine clinical practice in India. One more question is there: is Lynch syndrome inherited as dominant or recessive pattern? So I think we have molecular oncologists with us. Dr. Vidya, she could tell you better than me.
It is, yeah, it's a dominant pattern.
Yeah.
Essentially.
So it's the dominant pattern. But yes, it could have a variable penetrance. So variable penetrance could lead to certain members being not manifesting throughout their lifetime.
Disease. Yes.
Yeah. So
there is another question on onset of CRC, ethnicity. Do you think population genomics is important? Do you think knowing the population-specific genomics?
Okay, so I'll ask this to Dr. Olimova. Dr. Olimova, how common is this colon cancer in your country? Is it very common, or it's less common? Colon cancer.
Yes. Yes, in these days, colon cancer is very common. I'm so sorry. Let me just switch on the light. Excuse me. So
Dr. Elaine could take it. Yeah, Dr. Elaine could take it. Yeah. Okay. So, now we can see you. Yeah, yeah. Okay. We are so sorry to. Yeah, I'm so sorry to get you back here. Yeah. But,
so did you ask?
The question is that does ethnicity, does geography have an impact upon the incidence of a cancer? That's the question.
Okay, so it's a good question now, because I'm studying now. I collect 100 foundation datas, NGS. So now I am studying MLS, MSH, according just in Uzbek population. So we will see what result will be. So because it's very important, and
yeah, so you understand that it's important. And so Dr. Elaine, in Philippines, you see colon cancer less common, more common?
More common. It's one of the top cancers in the Philippines. If I'm not mistaken, it is the third most common cancer here in the Philippines. Yes.
Okay. Dr. Chandrashekhar, how is colon cancer? It's like relatively less common, more common?
It's one of the dominant cancers in cancers. I would say that in males, it's about somewhere around third most common or fourth most common. And then, females, it's about fourth or fifth. It's a huge burden when it comes to oncological malignancy. The colon cancers, colorectal cancers predominate the scene here.
So, Mr. Abhishek, you heard from our panelists that yes, ethnicity is important, population genomics are important. Certain cancers are endemic. For example, gallbladder cancer is endemic to India, particularly to the Gangetic belt. We don't know, but almost the other parts of the world will not have that much of gallbladder cancer as compared to the population in where I live, in the northern part of India. Similarly, Japanese have a high incidence of stomach cancer. That's why they have programs for stomach cancer, esophageal cancer, where they can go for early screening of these cancers. So a lot of dependence upon the ethnicity, as well as how we have our eating habits, as well as the kind of soil and the water where we are living. So it's a complex combination of the I would say the person's ethnicity or the pharmacogenetics, as well as the environment where we are living, which determines which cancer will be more prominent. In fact, in India and Bangladesh, we have a lot of head and neck cancers. Head and neck cancer is the #1 cause of cancer in India, and probably also in Bangladesh. But if you go to US, it is number 10. It is not the most common cancer. And there also, the kind of cancer, head and neck cancer they have are more of HPV related cancer, whereas we here have non-HPV cancer. So yes, there are differences. So
there was a question on gut microbiome.
yeah, we have already answered that question. Gut microbiome. Yeah.
Once again. Okay.
Dr. Saj,
May I ask?
okay, may I add?
Yes. Yes.
Ah,
Yes.
Go ahead. Go ahead.
Okay. Yes.
Yes, sir. Yes, sir. Yes,
Okay.
sir, please.
The one alarming situation what we are facing now, for the last few years, we found lots of young patients. As for example, the patients from third decades, usually we found lots of patients, as we have no population-based cancer registry. We have some facilities for hospital-based cancer registry. Here we found lots of huge number of cases, and actually we need, so I think that countrywide, we need to do research or find out some way to do for detections of the germline mutation in this respects. Sometimes actually I found some patients of the only second decade, so that is very alarming, and they have no family history. So, and in and most of also young patients, some patients have family history. I think that it is very alarming. I don't know what's the actually experience in India, like your in your perspective, but very relevant questions. And another matters I want to add in questions of Dr. Vidya, that of course actually where the facility is not available, we can do first lines in the first line settings or first or second line settings for metastatic colorectal cancer, only the targeted sequencing or the just targeted profiling or targeted biomarkers like the KRAS, NRAS, or some very 2 to 3 markers. But actually, if we need large scale mutation, then actually we need NGS based facilities. Then actually the cost will be minimized. As for example, in the management of the third line, fourth line, or fifth line metastatic settings, so we need to explore a lot. In that situations, we need some information of the total mutational burden also. There are more than 200 genes are required to sequence. So I think that in that situations, NGS based platform or biomarkers should be actually cost effective in comparison to just very few markers. Okay, thank you.
Yeah, points well taken. Okay.
Dr. Olimova had some comments here.
Yeah, did you mention about the microbiome? So my question is, improving the microbiome could improve the effectiveness of immunotherapy. So that is the question, first question. And second question, immunopet can replace NGS or not? I'm sorry, not just to effectiveness of immunotherapy. Just that in this day, most of countries use immunotherapy to use immune checkpoint inhibitors. So could be in future replace just investigating MSI or PD-L1. So the second question.
So yeah, so I agree with you. Yes, immunotherapy, the how a person will respond to immunotherapy will depend upon the kind of tumor statistics as we had discussed, because there are certain subset of patients which will respond very nicely to immunotherapy, others won't. So especially patients who have probably mutant tumors like KRAS or for example BRAF, they might not be responsive that much to immunotherapy. But if the tumor mutation burden is high, a lot of mutations are there. So if there's only 1 or 2 oncogenic driver mutations which are driving the tumor, then they are less likely to respond to immunotherapy because they might not have that PD-L1 overexpression there. But if there are a lot of mutations which are happening in that tumor, then that tumor is likely to have more new antigens being expressed upon the tumor. So they are more likely to respond to the PD-L1 inhibitors, leave alone the EGFR or the VEGF inhibitors, yes. But then the new immunotherapy drugs are more likely to respond if the tumor mutation burden is high. PD-L1 is also one of the surrogate markers of these tumors being highly immunogenic, because it has been seen that certain tumors will have TILS, which has tumor infiltrating lymphocytes. So there are certain colon cancer types which have TILS. So they have been seen to be high in especially MMR tumors. They found, when they found the pathology, they found that they were poorly differentiated tumors with a lot of TILS. So these are the tumors which can respond more to PD-L1 inhibitors. But we are still to have a concrete biomarker for response to these new immunotherapy drugs. So, any other aspect which I need to answer before?
I have a comment to Dr. Kamruzzaman from Pakistan. Like I was about to ask from the other panelists, the age at presentation, it's again very young age. The presentation age is very young nowadays, what we see in Sri Lanka. So it's one of the commonest cancers among male. First is head and neck, second lung, and third is colorectal. And nowadays we do see the males who do present in their 30s and 40s. I was about to ask whether it's same the other part of the Asian countries or other part of the world. And thank you so much that you came out with that comment.
Thank you.
So there was one small clarification that was asked by one of the attendees. Is MMR testing advised only on small biopsies or resected specimens? Also, is MMR IHC done irrespective of which side the tumor arises? Is it that, left-sided tumors do not require MMR IHC, or it is like all the tumors in colon or rectum, definitely it is advised to go with an MMR status? Sir, you are muted. Sir, you are muted, sir.
I think you can answer that question better than me. But yes, as of now, there's no sidedness for MMR because MMR can be available on both sides. So it is more likely to be sometimes on the right side. But yes, both the sides can have an MMR high. And the other aspect is about the gene panel, whether small biopsies or resected specimen. I think we can do in both the scenarios. In fact, we're able to do NGS on circulating tumor DNA or circulating tumor cells. So if the yield is good, the quality of the DNA we are able to extract is good, we are able to do these tests.
Okay, great. And then there's just one more question, sir. In circulating tumor DNA, would you look for only KRAS mutation status or any RAS mutation status or BRAF alone? Or you would look at the complete spectrum of mutations that the colon cancer would have for any given patient as a marker of prognosis or predictive biomarker for your treatment related decisions when we say liquid biopsy based profiling?
So again, liquid biopsy is a very broad term. We have three types of liquid biopsies. We have circulating DNA, we have circulating tumor cells, we also have so the third aspect, there were three types. So we have DNA, we have cell-free this thing, and we also have the circulating tumor cells.
Yeah. So among the three, the most robust one, where you get adequate yield of tumor associated DNA that gets shredded is the cell-free DNA.
Yeah.
And so
tumor DNA is the most, I would say, utilized into clinical practice. And then we now have many NGS-based panels out on this circulating tumor DNA. So it is becoming more and more richer. And I think once we have better platform, we are able to forego biopsies at multiple progressions. We might not require biopsies to be done at each progression. So there's a time which will come in very near future where we'll have these offering multiple genes to be evaluated on this DNA. Because what happens is, again, the kind of DNA we are able to extract from 10 ml of blood is not that great to have all the genes being assessed. But then yes, over time we'll have more sensitive assess where we are able to have at least 20, 25, 30 genes being assessed on circulating tumor DNA.
Mm. Okay. Yes, thank you. I think
Dr. Elaine had some points. She had raised
yes,
some questions.
yes, Dr. Elaine.
Yeah, I have a question. What is the incidence of actually the molecular markers changing once you do the repeat liquid biopsy, or you repeat it on progression, repeat it on recurrence, as compared to the original specimen where you do the molecular markers? Would it also matter because of tumor heterogeneity? Because the first specimen will be, for example, in this case, from the colon, and then the repeat biopsy will be from the liver.
So, Dr. Vidya, I think you should answer this question. Do you feel that?
So the good thing about liquid biopsy is it gives you the holistic presentation of the tumor as a disease. The first and foremost advantage of doing liquid biopsy is tumor from all the metastatic sites would shred the DNA into circulation. Therefore, all the sites where there is an active tumor which is shredding DNA into circulation, you get a complete picture of the disease, a holistic picture of the disease by looking at the mutation spectrum of the cell-free DNA. So in that way, your question gets answered that be it primary, be it metastatic, one has been able to achieve, at least we are not going and doing a hand picking on that to see. But having said that, people have verified in a few clinical studies to show that mutational profiling on solid tumors, particularly primary versus metastatic, by and large, only when the metastatic site, the recurrence happens at a metastatic site and not at the primary site, you might see some additional markers which would add to the primary markers. But by and large, the primary driving mutations do not just disappear. So it becomes more like a clonal evolution. And cfDNA, kind of, as of today's technical knowledge that we have in understanding this disease, we have cfDNA as a tool where you get the complete holistic picture of the disease by doing a molecular profiling on the cell-free DNA. And exome-based profiling is something which people have attempted, and targeted sequencing is something which has become very successful. And here again, as Dr. Sajjan mentioned, and others also, like Dr. Rumman was also mentioning, looking at single biomarker is okay. But what happens is when the cancer evolves, you definitely see more mutations. You unless you want to understand where the disease is moving forward, planning the next line of treatment might have a significant impact on the mutational spectrum that you see as you move on. Therefore, a broader gene panel will have a better understanding in clinical decisions. That is something which has come out from multiple clinical studies. So that's our understanding as of now.
May I add a little bit here?
Yes, sir.
Yeah. Okay. I think understanding the molecular profiling in total with various things outside the clinical practice scope now, we are looking at only limited number of mutations for the clinical decision making. Knowing the further more mutations apart from the routine use will also help in pushing the patients for the clinical trials.
Mm-hmm.
For the new targeted therapies, and then with respect to the new mutations, that is the way forward. I think we, if possible, all resources are falling in place. I think the full molecular profiling is advised or favored. That paves the pathway for the future treatment decision makings with pushing patients for the clinical trials if and when they are available there based on the profiling. Like pick 3CA. Currently, there is no standard treatment for the colon cancers, unlike the breast one. But these patients can be put to the clinical trial where there is a study going on. Then tomorrow it may become a standard of care. Yeah.
Sure.
Thank you.
Yes. So I guess there are not many questions anymore.
Dr. Vidya, Dr. Maqsood had some comment or a question.
Yes, yes,
Yeah,
Dr. Maksud.
if you allow me, now we are talking about the rough RAS mutations on colon, and then the blockators of the EGFR. But we use on the third line TKIs also. There is tyrosine kinase inhibitors also. I have like that question. Do we need to check the rough RAS mutations for tyrosine kinase inhibitors? I mean what was this? I cannot remember the name of that one. Regorafenib.
Okay. Regorafenib.
Yeah. Do we need to check for that?
Well, a medical oncologist call.
So
I don't think so.
for regorafenib is a VEGF. It's a multi-tyrosine kinase inhibitor, but more active on VEGF. For that, we don't usually check because VEGF is one of the pathways. So there are two pathways that are almost always active. One is EGFR, other one is VEGF. These are always active in colon cancer. Only issue is that sometimes when EGFR is overexpressed, still if BRAF is negative, then or BRAF is mutated, it might not really work that well. So same way, VEGF is almost always there upregulated in colon cancer. So we use regorafenib. We also have aflibercept, which are oral inhibitors of VEGF pathway. So for them, we don't usually require because we know that these pathways are going to be important in vast majority of colon cancer.
Yeah, it's always interesting for me. Do we use it in the first line like that without checking the rough RAS mutations, regorafenib plus chemo? That's always interesting for me. Why we need to check for cetuximab or the for bevacizumab to choose the one of them? Without that, only using that with the multi-kinase inhibitors with other chemos. It's just like my things.
Yeah, because everything has to be driven by trial. So whenever a new drug comes, it always comes to the third or fourth line, and then they try to move it to second line, first line. So there must be trials that are ongoing with regorafenib in the first line. As of now, I am not aware of any trial which is found to be positive in first. That's why it's not in the first line. But yes, if tomorrow a trial comes, it shows that regorafenib is better than using bevacizumab, or there's a head-to-head comparison of bev plus FOLFOX to regorafenib plus FOLFOX, and it outshines it, then we'll adopt it.
Okay.
Thank you very much.
Yeah. So if there are no more questions, we would like to thank Dr. Sajjan for this wonderful moderation of today's session. It has been a great educational learning experience today. And thanks to all the panelists who have taken a lot of time on a weekend, on a Saturday evening to be with all of us here to discuss on your sharing your experiences in how you manage metastatic colorectal cancers. And we thank you all once again with Dr. Sajjan, and you all have a nice weekend.
Thank you, ma'am, and thank you everybody for such lovely interactive meeting. And I think all the panelists would have also enjoyed the session. And we had a really good audience having so many questions. We'll be more happy to have those questions whenever they're able to access us. I'll be happy to share our details with them. And I'll request POBASE to also share our details with the attendees. And look forward to more such interactive sessions.
Yes.
Have a great weekend and stay safe. And bye-bye to all of you.
I want to express my gratitude. Okay, thank you. Actually, it's a great pleasure for me in this international to be here in this great international platform. And I wish that actually we should be keep in touch and for future approach, and we can do a collaborative approach for doing some innovative research or collaborative work. And also we can join these type of sessions the future, because I think that it is very helpful and will encourage us a lot to going for further approach. And I'm really delighted and grateful the POBASE for actually arranging such type of novel initiatives. Really wonderful.
Thank you so much.
Thank you.
Yeah, we shall keep in touch.
Yes, definitely. Bye. Bye-bye.
Thank you to knowing all the people from the different parts of the world. And then it was a great pleasure to meet and then share everybody's experience and all that. It will enhance our knowledge as well. It's a learning process for me as well. I can say that a few things you do pick up here and there. Yeah, it is a great experience. Yeah, thanks. Thanks for knowing all of you. And then we'll keep in touch and then have a collaborative work as Dr. Monk said. Yeah.
Yes,
Okay.
definitely.
Yeah.
We
Yeah.
look forward.
Yeah.
Have a good evening.
Have a great weekend,
Have a
all of
good
you.
evening.
Bye-bye.
Thank you so
Good
much.
evening.
Bye.
Goodbye.
Bye, Dr. Sajjan.
Bye. Bye. All of you, sir. Bye. Bye.
Bye.
Bye. Bye.
Okay. Thank you.